Hello and welcome to Chapter 5. In today's lecture, we'll be discussing everything about infection. Today, we'll relate the development of infection with the 3 lines of defense. We'll discuss different microbes and the ways they could become pathogens to human host cells. We'll differentiate between those different microbes. We'll determine the measures to break the chain of infection at each link. We'll identify the phases of acute infection. We'll discuss the potential complications of acute infection. We'll also talk about those clinical manifestations, diagnostics, and treatment modalities against various types of infection. And also we'll have several clinical models to apply these concepts to. So at this point, we have already discussed the 3 lines of defense, and at this point, we're discussing what happens when we don't have an adequate response with those previous 3 lines of defense. So what that is that the first line of defense, which is our skin and mucous membranes, that has failed. Our second line of defense, which is the inflammatory response, has failed, and then the third line of defense is our immune response, which has also failed. So again, we are at the point where once all of those lines of defenses fail, we are at the point where we get an infection. This is also known as disease spread. It is really considered a state of cellular, tissue, and organ destruction resulting from invasion by microorganisms. And again, focus on that word invasion. All of those lines of defense have failed, which allowed those microorganisms to invade the human host. So you do have different types of pathogens that would do this. And it's also good to know that you do have MDROs, or multiple drug resistant microbes or organisms. And unfortunately, if we have too many of these organisms and they affect too many people, we do see globalization and spread of harmful microbes with these infections. And a prime example of that would be the COVID-19 virus as of most recent. So let's talk about the different types of pathogens that we'll see. So we do have different types of pathogens that could potentially result in pandemics, as we saw with the COVID-19 virus. But viruses are not the only types of pathogens. We have bacteria, we have mycoplasmas, chlamydia rickettsii, we have fungi, we have protozoa, we have helminths. These are the different types of pathogens that can infect a human host and cause an infection, not only an infection in that one individual, but it could potentially result in worldwide spread if it's not controlled. So let's talk about these different types of pathogens. We have bacteria, which are characterized as single cell prokaryotes. They do have a cell wall, and it is the most common infectious organisms. And within the bacteria category, we have several subcategories. You have anaerobic versus aerobic. We have gram-positive versus gram-negative. We have different shapes of bacteria. We have spherical, spiral, rods, comma shaped. We have all kinds of bacteria, but again, this is the most common and the most infectious organisms that we can see. We also have viruses such as COVID-19. And what viruses do is that they require a host cell to replicate. So one healthy cell is eventually invaded by one virus, and that virus uses that one healthy cell to proliferate and eventually cause something called lysis, or bursting of the host cell. Once that virus is causing lysis in that cell, the virus has already replicated more times within that cell and has spread throughout the body. So viruses are unique in that they do require a host cell to replicate, and that's different from bacteria, which they don't require a host cell to replicate. They just infect the organism and they proliferate without the use of a healthy cell. Mycoplasmas, there are different types, but just know that the mycoplasmas and chlamydia and rickettsii, they have characteristics of both bacteria and viruses. And that would be an extensive conversation to notate the difference. Just understand that mycoplasmas have characteristics of both bacteria and viruses. Then we will move into fungi, and fungi can either be unicellular, such as a yeast, or multicellular, such as a mold. Fungi are different from viruses and bacteria in that they just proliferate. And again, it could be unicellular or multicellular. we have protozoa, and these are different because they have irregular shapes or they change shapes without cell walls. So I've mentioned earlier in this lecture that bacteria have cell walls. Well, protozoa do not, and that's one of the main distinguishing factors between those two. So don't get the word prokaryote and protozoa confused. That is not the same thing. Prokaryotes are single-celled microorganisms, particularly bacteria. Protozoa, they don't have cell walls, and they are irregular and change shape, whereas bacteria, they do have cell walls and don't change shape. We have helminths, and those are generally your worm type pathogens, and the most common type you may hear of is a tapeworm, and that is something that develops within the intestinal tract, of course, and they proliferate and grow based off of the nutrients that it's getting from the host. So again, we have these different types of pathogens, and there are different characteristics and descriptions. Just notate the differences between those as you're looking at your material. So earlier I mentioned the different types of pathogens and their different varieties of characteristics. Now we're moving on to how pathogens affect the population. And there are different factors that affect that, and we do term that the pathogenicity. So how does it begin and how does the disease spread based on the characteristics of the pathogens. So we do have different factors that affect pathogenicity. We have virulency, which indicates the potence of the pathogen, and this is related to the number of cases of this disease from this pathogen in a population. So basically, the number of cases of individuals affected with this disease is compared to that of the number of people that could have potentially been exposed to that pathogen that caused the disease. We have infectivity, which is a proportion, and this proportion indicates the number of exposures needed to cause an infection in the individual, and it is based on the pathogen's ability to enter, survive, and multiply in the host. So this is basically the survival rate inside of the host particularly. Now we'll talk about toxigenicity, and this is the ability of the pathogen to produce harmful substances or toxins that increase host cell tissue damage. So when we talk about toxigenicity, it's just like what it says, toxic. How can it infect the host, or how can it create damage to the host based on these substances that it creates? We have antigenicity, which is the level at which a pathogen is viewed by the immune system as foreign. So this is based off of that individual's immune system, and if it has the ability to determine that this is actually a pathogen and it is dangerous. And sometimes people's antigenicity is affected based on their immune processes. And again, we are talking about what happens when the third line of defense fails, and that is the development of infection. So when we have antigenicity, the immune system has failed and does not recognize that this pathogen is foreign, which ultimately results in no immune response developing, which means that this pathogen can proliferate in the host. We have antigenic variability, and this is the alterations of the antigen that shows variation. So these variations would basically show that the body can't recognize this antigen. So it changes over and over again, causing a delay in your immune response. And those variations in the pathogen basically mask that pathogen, and it's still causing those same signs and symptoms and is infecting that host and is causing issues with the host. However, the fact that it changes variations makes it very hard for the immune response to define it, recognize it, and ultimately destroy it. Then we have pathogenic defense, which is the pathogen's methods to avoid destruction by the host. So this could very well be that the body does recognize that there is a pathogen within the body. However, the pathogenic defense, it could be elevated or effective where the body's immune system is not able to target. So the difference between antigenic variability is that the antigen or the pathogen is changing multiple times, whereas pathogenic defense, it is recognized by the immune system, but that pathogen is able to prevent the mechanisms of the immune process. And one of those examples would be phagocytosis. And normally that's where a white blood cell engulfs the pathogen. If there's a capsule, for example, surrounding the pathogen, it protects it from phagocytosis. So therefore it's not engulfed. We have co-infections, and that is the simultaneous occurrence of two hosts infections. And one of the most common examples of this is chlamydia and gonorrhea. So again, there are two or more infections. It doesn't have to just be two, it could be several, but they're infecting the same host, causing more intense issues. We have superinfection, and that is an infection that arises that is already present within the host. So a superinfection is generally the response to antibiotics and the overuse of antibiotics or antivirals. Most times they will tell you to make sure you take the full course of the antibiotics as prescribed. And the reason why is because if you're prescribed 5 days of antibiotics or antivirals or whatever your antimicrobial therapy is, and you only take 2 or 3 days, you have allotted that pathogen to, one, be killed off a little bit, but because it understands what type of antimicrobial therapy you are experiencing or that patient is experiencing, it may develop a more intense pathogenic defense, which would cause it to proliferate more and cause more of an intense infectious cycle. So again, you do have different factors that affect pathogenicity, and I want you to understand that it's just not just one level of this. It can have several of these pathogenic factors that make it more potent than others. So now we are talking about the chains of infection, and you'll notice that this is literally a cycle. So each one of these areas, the infectious agent, the reservoir, portal of entry and exit, means of transmission, and susceptible host, all of them must be complete in there in order for the chain of infection to be complete and ultimately cause an infection. So the best defense of the chain of infection is to break it at each chain. And you'll notice on this photo here that it gives you examples of the prevention of the spread at different chains. So do understand that first and foremost, hand washing is the most important and the most effective way to break the chain of infection, because you'll see that translate across several modalities in the areas of the chain of infection. So we have the infectious agent. You have infectious agents. Those are your microorganisms or pathogens that would cause the infection. Then you move into the reservoir, or where those pathogens can live, which is people, equipment, water, food, anything that can allow the bacteria to sit. So one of the ways that you can break the chain of infection here is by sanitizing the environment if that organism lives on dirty equipment. Or if it lives in an individual, you can use antimicrobial drugs to help kill off that virus or bacteria, whatever the infectious agent is. And that way it won't be able to proliferate and spread. You have the portal of exit, and this is anything that leaves the reservoir. So that can be through secretions, bodily fluids, droplets, excretions, anything that comes out of the host or the reservoir, excuse me, would cause the spread of this infection. So this is the method by which that infectious agent leaves the reservoir and will eventually move into the means of transmission. So you'll notice that, again, one of the first ways that you can prevent infection and break the chain is through hand washing. You want to dispose of trash, you want to cover secretions, you want to protect yourself, things along those lines. As far as the portal of exit, once that infectious agent moves from the portal of exit, there is a means of transmission, and that can be anything. That can mean direct contact, that can mean contact with an inanimate object, that could be ingestion, that could be droplets, airborne. The means of transmission is how the the actual infectious organism is spread. So this is where you'll see your precautions come into play. One of the preventions of the spread of infection is by instituting your precautions. So if there is airborne transmission, you want to have airborne precautions in place in order to help protect against that. If there's droplet formation, well, you want to have droplet precautions in place in addition to your universal precautions or your standard precautions. As far as ingestion, you want to make sure that there's safe food handling. Again, your means of transmission is how does this infectious organism move through the portal of exit to the portal of entry within the next individual. So you have the portal of entry. If you're not successful in protecting yourself with the means of transmission, this infectious agent will go in through any of these portal of entries. That could be through your GI tract, through the mouth, into the esophagus, into the stomach. You have your respiratory tract. You have through broken skin, mucous membranes. These are all potential areas of entry for this infectious agent. So this again further highlights the need for your precautions. If you're not protecting these areas with masks and face shields in your gowns and having gloves on your hands, or even covering injuries with broken skin, you have a potential portal of entry for infectious agents. Then we'll move into the susceptible hosts, and this is where you have a person that is susceptible or would be easily infected by this infectious agent. So this would be individuals that are immunocompromised. These are individuals that have burns because their skin is already compromised. The elderly, their immune system is not as great, or individuals with diabetes. You have different types of susceptible hosts in the chain of infection. So if you are trying to break this, you want to make sure that you recognize who are the individuals that are at risk for infection, and then you want to make sure you treat any underlying diseases that could make them more susceptible to infection. So again, you have different chains, and it's important to understand how to break the chain infection to prevent the spread of infection. So here we have the phases of acute infection. So this is where your chain of infection has completed itself, and now you have the individual that is exposed, or your susceptible host is exposed and now will be exhibiting the signs of infection. So first you start with your exposure, and then you have your incubation. So this is where that bacteria or pathogen, virus, whichever microorganism has infected that individual, that's where it sits and it starts proliferating. You'll hear me use this word a lot: proliferate, 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 and that means it just develops and spreads and multiplies. But here, this is where it is multiplying to the point where it may start causing some general signs and symptoms. That could be your fever, that could be just being weak, that can be just not feeling your best, malaise, and that's where you move into your prodrome period. So prodrome is general manifestations. It's not specific to an acute illness. And then once that bacteria continues to proliferate and continues to affect that organism, you have the acute clinical illness. So what differentiates this from the prodrome stage is that prodrome is general signs and symptoms, whereas you have acute clinical illness, which is confirmed signs and symptoms. That is tall tale signs for this particular disease. For example, if an individual is affected with tuberculosis, you may see a fever of 100 degrees. Well, it's just a fever, right? That's a general symptom. It's a systemic clinical manifestation. Whereas if we know this individual has tuberculosis, generally they have hemoptysis, which is coughing up blood. Generally they have that Gons complex, which is the lesion within the lungs, and you'll see that on a chest x-ray or a CT chest. So this is the acute clinical illness. You see some very specific signs and symptoms of the disease that would lead to diagnosis. So once you have those signs and symptoms, hopefully you go to a place of resolve, and that place of resolve is called convalescence. This is where those signs and symptoms start dwindling away. This is where the individual starts to feel better. Those signs and symptoms are starting to subside, and this is based off of treatment, of course. If the individual's being nourished, hydrated, if they are being treated with antimicrobials, you should see individual signs and symptoms move from the acute state to the more healing state, if that makes sense. So again, you move from exposure to incubation to prodrome, to acute illness to convalescence. Make sure you understand the difference between prodrome and acute illness. You have non-specific symptoms in the prodrome stage versus acute clinical illness. You have very specific signs and symptoms. So unfortunately, we have times where infection does lead to complications, and one of the main complications I want to discuss today is called sepsis or septicemia. And all this means is that there's a microorganism that has spread through the blood systemically, through the blood and through the body, causing organ dysfunction. So if we get to the point of organ dysfunction, it's called septic shock, and that can lead to death. But in its most simple form, if you just have more bacteria in the bloodstream than you're supposed to, this is sepsis. And it depends on the type of organism that is circulating through the blood. So if we're talking about bacteremia, this is a bacterial infection circulating through the blood, and it's in higher forms. So sepsis is a medical emergency, essentially, because if it goes untreated, it can lead to death. Again, I told you about sepsis, and then, when we have the area of organ dysfunction with sepsis, then that can lead to death. Again, that process moves from sepsis to septic shock. And unfortunately, it does lead to death. So the main thing about sepsis, and in your clinical practice, if you have someone that's exhibiting signs and symptoms of sepsis, high or low temperatures, high heart rate, high or low blood pressures, they have history or have been diagnosed with some sort of bacterial infection, that can be a UTI, things along those lines, that can lead to septic shock. Or even if you look at an individual's lactic acid levels that are elevated, that can be a sign that sepsis is impending. And once sepsis onsets, the progression is very rapid. That's why you have to recognize those signs and symptoms immediately and then take action at that point to prevent septic shock and to prevent death. Then we have the complication of infection, chronic infections. So this can result from superinfections or co-infections, and we describe what those are. Superinfections are normally the result of the inappropriate use of antimicrobial therapy. You have co-infections that can exist at the same time. And the thing about chronic infection is that it comes and goes. There's exacerbations and then there's remissions of these infections. So when you have this type of complication, you want to make sure you're treating it as such. And when you're educating your patients, you want to make sure that you do describe to take the full course, make sure that they're doing appropriate treatment methods overall to help prevent that chronic infection from coming back. So again, sepsis, medical emergency. It can lead to septic shock and death, whereas chronic infection, we have these remissions and exacerbations. Now, it can get to a point where these super infections lead to sepsis because it keeps coming back, and maybe that time that it comes back, it's an overproliferation of this bacteria or pathogen, and it causes the symptoms of septic and ultimately septic shock and death. But generally, chronic infections, they come and go, and they're treated, and then you may have to find other treatment methods to help that haven't worked in the past. So we have generalized manifestations of infection. So this is across the board. You'll have those local manifestations, and a lot of these are very similar to that of inflammation. You'll have heat, incapacitation, or immobilization of that area of the body. You have pain, edema, redness, also known as erythema. You have lymphadenitis, purulent exudate. These are all local manifestations of an infection. Then you move into systemic manifestations, and that's your fever, weakness, headache, malaise, anorexia, and nausea. So again, note the difference between local manifestations for infection, which do mimic that of the inflammation response, and also understand what's a systemic manifestation of infection. We have generalized laboratory tests. Normally you'll pull a CBC, which would include your white blood cell count, and normally those CBCs have differentials, so you can see what types of cell or red blood cells or white blood cells are within the blood at the time of infection, and you can indicate the white cell count. White cell count always leads to indication of infection. So you can have leukocytosis, which is an elevation in your white count, or you can have leukopenia, which is a decrease in your white count. Both of these would indicate that there's some sort of infection. You can look at your serum antibody levels to see if the body is fighting off infection or has developed antibodies against particular antigens that will cause those infections. You can look at different types of cultures, that's blood cultures, stool cultures, sputum cultures, wound cultures, and you can also have a sensitivity test. All of these are generalized laboratory and diagnostic tests for infection. So now we'll talk about the treatment of infection, and again, it always depends on the type of organism. We talked about a variety of pathogens. Earlier in this lecture, we talked about bacteria, viruses, protozoa, helminths, fungi. The antimicrobial drugs is a collect-all term for drugs that treat microorganisms. So antimicrobials is your overall drugs, and then you have different subsets of that. So you have your antibacterials that'll treat bacteria, antivirals that'll treat viruses, antifungals that'll treat fungi. So we do not use antibacterials to treat viruses because they're not made specifically for that type of pathogen. So if a patient asks you, hey, I have COVID-19, can I take erythromycin? Chances are the answer is no, because erythromycin treats bacterial infections, not viral infections. As far as treatment with the symptoms, you have fluids, rest, and analgesics that help with that pain or lack of nutrition at the time, and you always want the body to rest to help gather energy for it to fight off infection. So again, these are your generalized treatments of infection, and it always depends on the type of microorganism that you're dealing with. So here are our clinical models of types of infections and our concepts of infection. Feel free to take out your disease cards or your templates and fill them out as we talk about each one of these diseases. Here we have influenza, and it is caused by a viral infection. Influenza is a viral infection that affects the epithelial cells of the airway. So those are that first layer of cells in the airway. And eventually those epithelial cells are necrosed, or they die based off of this viral invasion. So individual with influenza, you want to place them on droplet transmissions because that is the mechanism of transmission or means of transmission. Influenza is spread by droplets. And one thing to note about influenza is that this virus actually changes every year. There's not one specific influenza vaccine. You'll notice that they'll change it every year because influenza changes in its genetic composition, which ultimately makes it change each year, and that's why they have to redevelop the vaccine, because it changes. We do have several manifestations that we'll discuss on the next slide. As far as being diagnosed, you have viral rapid assays, and this is where you have your swabs, your nasal swabs, and it will tell you almost instantly within an hour, 30 minutes to an hour, what type of influenza that you have. And of course, you have influenza A and influenza B. These rapid viral assays not only tells you if you're infected with influenza, but it tells you which type. And of course, you have to have a history and physical examination by your healthcare provider to be diagnosed with influenza. As far as your treatment, prevention is always the best thing first. You want to have hand washing and vaccinations every year. As far as symptomatic care, if you do have influenza, you want to encourage fluids, nutrition, and analgesics. And influenza is treated with antiviral medication, not antibacterial medication. Influenza has several clinical manifestations. We have fever, body aches, malaise, weakness, shortness of breath, nasal congestion and drainage, sore throat, chills. All of these would indicate that there's some sort of infection, and you'll notice that some of these manifestations are systemic and some of them are very specific. Again, we talked about how influenza affects the epithelial cells within the respiratory tract. That's where our sore throat would come because those cells are dying off. We have viral hepatitis, and it is an acute or chronic inflammation of the liver, and it is caused by several different hepatic viruses, and it ultimately results in hepatic necrosis. And again, we're talking about hepatitis hepatic. This is everything dealing with the liver. So you have several types of hepatic viruses. You have hepatitis A, B, C, D, and E, and the differences vary, and ultimately they are transmitted different ways, but overall you have transmission via the fecal oral route or by direct contact with infected blood and bodily fluids. As far as your diagnosis, you want to have a history and physical examination by a healthcare provider, and you'll detect viral antibodies in blood. So this would be your serum antibody test, and you are looking at anti-HAV, anti-HCV, anti-HDV, and so on and so forth. If you have antibodies developed against any of these viruses, that means you would result positive on the viral antibody test. So whatever you result positive for, that's what type of hepatitis you have. You have different labs. You have bilirubin, serum bilirubin, clotting times, and you also want to look at your liver function enzymes, and that would include your AST, ALT, ALP. All of those would indicate some sort of viral issue with your liver. As far as treatment, you want to do heavy hand washing, you want vaccination against hepatitis A and B, and you want to avoid fecal material, blood, and bodily fluids. As far as care, if you do develop hepatitis, you want to have fluids, rest, low-fat diet, and as far as your drugs, you want to use antiviral drugs and analgesics. Clinical manifestations, we have the prodrome stage, which are generalized manifestations. You have icterus. This is the equivalent of your acute clinical illness. And then we have recovery, which is the equivalent of convalescence. So prodrome, this is your generalized symptoms. You have fatigue, anorexia, low-grade fever. Icterus, you have jaundice, hepatomegaly, which means that your liver is enlarged. You have clay stools, and you have dark urine. And then when you go into a recovery period, you'll see improvement with residual hepatomegaly, or at least you'll see that liver size to go down in an individual. Next, we'll talk about tuberculosis, and it is caused by Mycobacterium tuberculosis. This is a bacterial infection, not viral. Tuberculosis is a bacterial infection, and it infects the lungs mostly. It is transmitted via airborne droplets, and it is considered a cell-mediated hypersensitivity response that ultimately causes the Ghon's complex if it is left untreated. You have diagnostic criteria. You'll normally see individuals get the tuberculin skin test, either the one-step or two-step PPDs. You'll see a chest radiograph, which would show that Ghon's complex and the consolidation in the lungs, and you'll also see sputum cultures. As far as treatment, you want to have the vaccination. And if the individual does end up contracting tuberculosis and it is active, you should put them in a private negative pressure room and initiate airborne precautions. And that includes wearing your N95 respirators, gown, gloves, face shields, things of that nature. As far as your treatment, again, this is a bacteria, so you want to use antibacterial drugs. So you'll have anonazid, rifampin, paranazid, and streptomycin. All of these would be appropriate treatment methods for a bacterial infection in tuberculosis. As far as your clinical manifestations, you have the presence of Ghon's complex on that CT chest or that chest x-ray. You have anorexia, fatigue, night sweats, hemoptysis, which is bloody sputum, weight loss, malaise, and low-grade fever. Here's the pathophysiology concept map behind tuberculosis, and you'll notice that there's a primary tuberculosis and secondary tuberculosis. When you're first infected or you have primary tuberculosis, it is a cell-mediated hypersensitivity response. It triggers the inflammatory response, which ultimately results in that Ghon's complex. You'll see this lesion within this example here with the lungs. Eventually, that lesion grows dormant, and that's where you have latent tuberculosis if it's a dormant lesion. You have secondary tuberculosis where there's reinfection, your signs and symptoms redevelop, that Ghon's lesion can get bigger, and you'll see that tuberculosis will become more progressive and the symptoms can become more violent and more aggressive within that individual. So again, if that lesion's still there, you'll see a lot of that in individuals with tuberculosis. Next, we have the urinary tract infection, or a UTI, and it is caused by Escherichia coli, or E. coli for short. And this bacteria is featured in the urinary tract. So again, urinary tract infections are caused by E. coli. They affect the urinary tract epithelium, that first layer, and it causes cell necrosis, which you'll see the clinical manifestations of that. As far as your diagnostics, you want to have a urinalysis, urine sensitivity and culture, and you may even see individuals get a leukocyte esterase dip test, and that just tests for the presence of leukocytes in the urine. Of course, you want to have a history and physical examination by the healthcare provider. As far as your treatments, you have antibiotic drugs because this is a bacterial infection. E. coli is a bacteria. And you also want to increase fluid intake to help dilute the presence of E. coli in the urine. So here are clinical manifestations of a UTI. We have dysuria, urgency, frequency, hematuria, and cloudy or purulent urine. So next we have acute pyelonephritis, and this one is also caused by Escherichia coli, or E. coli for short, but this is not in the urinary tract. This one is featured in the kidneys. So acute pyelonephritis has very similar signs and symptoms of that of a UTI, except the place of infection is not in the urinary tract. It is actually in the kidneys, and there are several risk factors for this. You have kidney stones or renal calculi, which causes a urinary obstruction. You can have incomplete bladder emptying, which causes urine stagnation. If there's urine stagnation, it backs up into the kidneys, causing this bacteria to proliferate. You have frequent intercourse, which irritates the urethra, and this bacteria travels up into the kidneys. You have exposure to STDs or STIs that can cause this, and you also have hormonal changes which can reduce the urethral peristalsis. When you have urethral peristalsis reduced, that also causes urine stagnation and backup into the kidneys. As far as diagnosis, you have the presence of the symptoms that we'll discuss in a few. And you want to also get a urine analysis, microscopic evaluation, urine culture and sensitivity, and you may have kidney ultrasound to determine whether or not you have blockages in your kidneys. As far as your treatment, you want to, again, use intravenous fluids. You want to encourage fluids to dilute the presence of that bacteria. You want to use antibiotics because this is a bacterial infection. You want to also use analgesics for the pain, and depending on if the cause is by urinary obstruction with kidney stones, they will need to be surgically removed. The clinical manifestations include fever, costovertebral angle pain, nausea or vomiting, dysuria, urinary frequency, hesitancy or urgency, lower abdominal pain, or blood in the urine. And that costovertebral angle pain is right at the level of where your kidneys would be placed. So if you have that pain and it radiates, they normally call it flank pain too, but if it's there, then chances are that your kidneys are infected with this bacteria. Another thing to watch out for with pyelonephritis is that there can be some progressive scarring with the kidneys, and you have different phases of this scarring. You have the early phase, which the kidneys will swell. You have the progressive phase where the kidneys are starting to narrow, and you have your parenchyma, which is the outer layer of this kidney here, which are starting to scar. And then you have the end phase where that parenchyma has not only narrowed and scarred, but they have atrophied, and those cells in that area start to die. So again, you have different phases of scarring, and eventually that scarring does lead to death within the kidney cells. Bacterial meningitis is also a bacterial infection. At least the one that we're talking about is a bacterial infection. Just know that meningitis can be caused by different microorganisms. It can be caused by fungal microorganisms or viral microorganisms, but the one for our example today we'll discuss in meningitis, which is the bacterial version of this. And it results in the inflammation of the meninges in the brain and the spinal cord. So your central nervous system is affected by this bacteria. You see that inflammation that causes the development of fluid or exudate in the central nervous system, and that swelling and that exudate can block oxygen, which is needed to perfuse the brain. So when you have reduced oxygen to the brain, you'll see a lot of neurological signs and symptoms, which we'll go over in a few minutes. Now, the mechanism of entry into the nervous system, the central nervous system, is unknown, so we'll call this an idiopathic etiology. As far as your diagnostic criteria, you have to be diagnosed by a healthcare provider, history and physical. There will be the presence of Kernick's sign and Brudzinski's sign. I have a video tagged in this lecture that will help you look at the differences between those, but either one would cause suspicion for meningitis. As far as your blood cultures, you'll have those drawn to see if what type of microorganism is affecting or causing the meningitis, because as I've stated, it can be caused by several different factors. And then you have your cerebrospinal fluid analysis and culture as well. Treatments would be vaccination for prevention, and you can use antibiotics if it's a bacterial infection, corticosteroids, and fluids. Clinical manifestations are rapid and severe in onset. You'll have a severe headache, photophobia, nuchal rigidity, decreased alertness, loss of consciousness, changes in mental status, vomiting, seizures, fever, anorexia, and leukocytosis. Next, we'll talk about tinea, and the pathophysiology of this is that it is caused by a fungus. These are a group of fungal infections that normally occur in the nails, feet, or hair, and generally a dermatophyte attaches to this area and it produces the thickening of keratinized cells. In these areas, you have a high prevalence of keratin. So, of course, in the feet, nails, or hair, you'll get this overstimulation by this dermatophyte. It is transmitted via direct contact. As far as your diagnostic criteria, you want to do a history and physical examination. You want to do microscopic examination, fungal cultures, and a wood light examination. Now, those wood light examinations, it's just a UV light, and it shows the extent of which the fungus has spread. So there's different colorations with the UV light, and it generally indicates where this fungus is and how far it has gotten on the individual. As far as treatment, you want to focus on prevention first. You want to have proper hygiene and avoid infected individuals or body parts. And as far as drugs, you may have topical and oral antifungals to treat this disease. Clinical manifestations depend on the location of the infection. We have tinea capitis, which is ringworm, and normally this is featured in the head area. You'll see hair loss and breakage. You'll see raised borders if it's not in the hair, but again, ringworm has these features. You have tinea pedis, which is scaling, fissuring, and maceration on the feet. You have tinea cruris, which is also known as jock itch. You'll see a erythematous lesion or a red lesion on the penis, or you'll see raised borders similar to that of ringworm. And you have tinea unguinum, which you'll see discoloration in the nails or separation from the nail plate from the nail bed. Next, we'll talk about malaria, and this one is caused by a protozoa called Plasmodium, and it is transmitted by mosquito. So here in this example, the mosquito is considered a vector of transmission, or the means of transmission is a vector. That vector is the mosquito. So a lot of the treatment with malaria and prevention would be to reduce the means of transmission, which means to reduce the instance of being exposed to your vector. So mosquitoes. You have an incubation period of 1 month from exposure, and then that's the point where you'll start seeing the signs and symptoms specific to malaria. You have diagnostic criteria. You have to have a history and physical examination determining that you are showing those clinical manifestations. Some risk factors would include recent travel to an area of high prevalence, normally in your sub-Saharan areas, African areas. You have different laboratory testing. That would include a CBC, and in that CBC, you're looking at your differentials, your white blood count, hemoglobin levels, hematocrit levels. You're also looking at your red blood cell counts. You want to look at the peripheral blood smear, and that's literally a picture that they're looking at to see if the plasmodium is within the red blood cells. You'll look at the platelet count, liver function enzymes, and also your lactate dehydrogenase. As far as treatment, you want to avoid mosquitoes, and that's a prevention mechanism. You want to use a bed net during sleep if you're going camping. You want to wear long sleeve clothing. You want to use insect repellents, but specifically the ones with DEET, because they will kill the mosquitoes the best. And the treatment will also include anti-malarial drugs. So that's your quinolines, your antifolates, artemisins, and then you also want to use antimicrobials and to treat the generalized manifestations of pain, malaise, fever, you want to use antipyretics. Our clinical manifestations include headaches, fatigue, cough, shivering, high fever, malaise, excessive swelling, and joint and muscle aches. As I've mentioned, there is a peripheral blood smear. If you'll notice in this slide, you'll see the red blood cell, and you'll see this purple like dots in the red blood cell. Those purple showings are the plasmodium. So if you have a blood smear showing this, you are diagnosed with malaria. Well, that concludes our chapter discussion for today. Make sure you complete your review of the chapter. Make sure you do your guided learning questions. Make sure you complete your disease cards. Look at the case studies and activities that we have featured for this chapter. Make sure you review all of those things, including the pathophysiology, clinical manifestations, diagnostics, treatment, and application to your understanding. Make sure you quiz yourself and others, and make sure you answer those questions in the back of the textbook. As far as your clarification, feel free to reach out to me for questions, and I'll be more than happy to clarify or assist. Thank you and have a good day.